Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clinic, serving as the allocated session assistant to ensure a seamless experience. Clinic proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clinic serves as a digital partner for this event hosted by Indian Society of Anesthesiologists, and the focus of today's session is segmental spinal anesthesia and update. Now, I would like to invite Dr. Praveen sir to proceed. Over to you, sir. Thank you.
Thank you very much. Good evening, everyone. It gives me immense pleasure to welcome you all to this month's academic session hosted by the Indian Society of Anesthesiologists, Visakhapatnam City Branch. I am Dr. Praveen, Secretary City Branch, and it is truly delightful to see the screen studded with leaders of ISA. On behalf of the City Branch Visakhapatnam, I welcome Dr. Kameshwara sir, past National President ISA, Dr. Kuchil Babu Garu, past National President ISA, for today's session. Before we start with the proceedings, let us seek the blessings of Goddess Saraswati.
सरस्वती नमस्तुभ्यं वरदे कामरूपिणी विद्यारम्भं करिष्यामि सिद्धिर्भवतु मे सदा पद्मपत्रविशालाक्षी पद्मकेसरवर्णिनी नित्यं पद्मालयां देवी सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा.
May I now request our City Branch President, Dr. Aparanji Madam, Professor Andhra Medical College, to give introductory remarks.
Good evening and warm welcome to all to the today's program of ISA City Branch Visakhapatnam. Thank you, Dr. Naresh Paliwal sir, for accepting our invitation, and thank you all the moderators for accepting our invitation and presenting a warm way and for this good scientific session. Thank you also.
Thank you, ma'am. Today, we have gathered here for a very special session on a topic that is both relevant and evolving: segmental spinal anesthesia, an update. This technique redefines the way we approach regional anesthesia, and we are fortunate to have with us today one of the most respected voices in this domain. It is my honor and privilege to welcome Dr. Naresh Rao Paliwal sir, Professor Emeritus at DRPD MMC Amaravati, a teacher of teachers and a name synonymous with excellence in segmental spinal anesthesia technique. With over 50 invited lectures and authorship of a recent handbook on thoracic segmental spinal anesthesia, Dr. Paliwal sir's contribution to the field is truly remarkable. We are honored to have him today guiding us this evening with his insights and experience. We are equally delighted to welcome our distinguished panel of moderators who bring academic brilliance to this event. Dr. Vijesh Venugopal sir, Honorary Secretary of ISA Kerala and Principal of KMCT Medical College, a dynamic academician and respected leader in anesthesiology. Dr. Pratibha Natarajan ma'am, Honorary Secretary of ISA Pondicherry and Professor and Head of the Department of Indira Gandhi Medical College, Pondicherry, known for passion for education and tireless work in academic upliftment. Dr. Y. Govardhani ma'am, Professor at Pinnamaneni Siddhartha Institute of Medical Sciences, Gannavaram, a dedicated teacher and a calm guiding force in clinical anesthesia. We hope this evening will not only update our knowledge, but also inspire new thoughts and reflections in our clinical practice. Thank you once again for being here. And now over to the moderators.
Thank you, sir. Good evening, Dr. Naresh, sir. Today, I would like to thank the ISA City branch for inviting us for this very wonderful talk, which we are going to hear from Dr. Naresh, sir. I think till now, all of us are still in the panic mode when we talk about segmental spinal. And to clear that, we have our very own Dr. Naresh, sir. And I hope all of you are going to benefit from this session. And I think all of us will start practicing segmental spinal. Over to you, sir.
Hello. Can I start sharing my screen?
Yes, sir. Yes.
I'm not able to share. Please allow me to share. The host isn't allowing sharing for this meeting, so kindly allow me to share my screen.
Rimpa, please see, sir is not able to share this thing.
Yes, now I am able to share my screen. Is it visible?
Yes, sir, it is visible.
Yes, sir.
Okay, just a minute. So, good evening, everyone, and thank you very much for inviting me to this ISA Visakhapatnam. Thank you, Dr. Praveen, and all the dignitaries, all the panelists, and all the delegates. This is still a controversial topic, but not a new technique, but evolving. And rightly said, it can be very useful in specifically very high-risk patients, if not used for all routine cases. So without wasting much time, I will start with my presentation on segmental spinal. So segmental spinal is not a new technique. As I already said, it has a definite past. When Thomas Janesco proposed the term general spinal anesthesia by giving spinal at T1, T2 for head, neck, and other surgeries. Then in 2006, Andre van Zundert gave thoracic segmental spinal anesthesia with combined epidural for a case with severe COPD or laparoscopic cholecystectomy. And since then, during the COVID time, when everyone wanted to avoid general anesthesia, it became the very red hot topic. And the way it's going, it looks to have a bright blue future. There was an article in April 2022 about defining the role of thoracic spinal anesthesia in the 21st century. The conclusion they provided was very loud and clear. Despite the absence of larger trials, there is evidence from the small cohort studies and multiple case reports that thoracic spinal anesthesia may be considered a safe, feasible, effective alternative anesthetic technique and may be used in patients where other anesthetic techniques pose a higher risk. There was actually a chart about the different drugs, doses, and this thing in that previous publication, but that had some fallacies in that, and I just notified to the editor, and this is the chart which is recently published in 2025, the corrected one. It has the correct doses about the same publication. And there was again an article in April 2023 about thoracic spinal anesthesia for thoracic surgeries. And given the trajectory of the thoracic surgery and anesthesia, it holds promise to form part of the thoracic anesthesiologist armamentarium in the future. I also had a privilege to publish my article recently in British Journal of Anesthesia, Thoracic Segmental Spinal Anesthesia Expanding Applications while Keeping It Safe, and also had an opportunity to review few articles in same BJ. Now, what is segmental spinal? The term is often used synonymously with thoracic spinal. But even the low doses of drug used at a high lumbar levels can produce a segmental effect. So the ideal definition should be blocking of the required dermatomes essential for the proposed surgical procedure with low dose injected near the targeted nerve roots. Lower the dose, more likely to produce a true segmental block. There are some factors which make segmental spinal feasible. At thoracic level, the spinal cord is positioned anteriorly, leaving a significant space between the posterior and the spinal cord. The nerve roots are slight and thin. Amount of CSF is comparatively less. Both these factors make blocking of these thoracic nerve roots easy with low dose injected at this site. There is no difference in the onset time for isobaric and hyperbaric drugs at thoracic levels, while the isobaric drugs may take a little longer time for onset at lumbar levels. There are some safety concerns whenever we talk about segmental spinal. The first and foremost is, can there be neurological injury when we give spinal at mid to lower thoracic or high lumbar levels before the cord is terminated? The second issue is ventilatory impairment. Can there be a ventilatory impairment with high thoracic nerve block involving the upper abdominal and intercostal muscles? Can there be a bradycardia and hypotension with the block extending T1 to T4, blocking the cardioculator fibers? And last but not the least, about the medical issues, as it is still not in the standard textbooks. Now coming to the first issue, the major concern is damage to the spinal cord. This is a midline MRI where you can see there is sufficient space between the posterior and the spinal cord, or while this space is not available at the cervical and lumbar levels. You can see it clearly in this next image. There is sufficient space between the posterior and spinal cord, allowing a safe entry of your spinal needle at these levels. This is pictorial depiction of the position of the spinal cord at thoracic, thoracolumbar, and cauda inguinal levels, which will make it more clear. Imbironi and Cuvier did a study on the low incidence of neurological complications after accidental dural puncture in thoracic epidurals. And they measured the exact distance at various levels, and they found the distance to be around 5.19 millimeter at T2, 7.75 millimeter at T5, and 5.88 millimeters at T10 level between the posterior and the spinal cord. Lee RA also did a study in various positions, supine, lateral, and sitting positions about the distance between the posterior and spinal cord, and they found the distance to be more in all positions at mid-thoracic levels, especially sitting position. You can see in the sitting position, this is the most. This is the position most of the anesthesiologists use for giving spinal anesthesia. The spinal cord sits ventral in the apex of the thoracic curve. You can see in this figure, and more so when you ask the patient to flex the spine. The distance between anterior and the spinal cord on left-hand side, distance between posterior and the spinal cord on right-hand side. Because of the angulation that is required to perform spinal at mid-thoracic levels, mid to lower thoracic levels, the distance between posterior and spinal cord is further increased. You may need an angle of 40 to 45 degrees to perform because of the angulations of the spinous process. You can see here the distance is almost 8 millimeter at mid-thoracic, while it is around 4.5 millimeter at low thoracic or high lumbar levels. The similar thing is true in pediatric patients. I will not go into details about the pediatric thoracic segmental spinal. There are some additional points favoring the safety of segmental spinal. You all must be giving thoracic epidurals day in and day out, and the incidence of neurological injuries during thoracic epidurals are quoted to be very less. Inadvertent use of higher lumbar or thoracic spaces by many anesthesiologists. In one study, it was found that only 29% of the expert anesthesiologists were correctly identifying the required interspace for giving spinal. They were either 1 or 2 or even 3 spaces higher than what they intend. That means they are inadvertently using these thoracic spinals already. The level of spinal cord termination is also variable. Can you identify a safe interspace in such patients? No. You are always 1 or 2, even 3 spaces higher than what you intend to. What you think is a L4-5 may not always be the same, as is confirmed with this ultrasound. What you think is L3-4 is 1-2 when confirmed with ultrasound. The position of conus medullaris, as I already told you, is variable, can be as high as T12, T11, 12, or can be up to L3 levels. The second issue is ventilatory impairment. Here, the main inspiratory muscle of respiration is diaphragm, which is usually unaffected. Expiration at rest is a passive process. Forceful expiration and coughing may get affected, but because of the low doses of the drugs used, there is minimal motor weakness, and that usually preserves the coughing ability. About the bradycardia and hypotension, the heart rate may decrease if the block extends T1 to T4, blocking the cardiocellular fibers. But because of the lumbosacral sparing and less minute dilatation in lower limbs, the right atrial filling is maintained, and that usually sustains the outflow from intrinsic chronotropic receptors located in right atrium and great veins. Also, the negative vein bridge reflex is not initiated. Less hypotension is due to less sympathetic blockade. About the medical issues and litigations, now there are n number of studies and publications and whatnot, and many PGs are taking this as a thesis topic. Now there is enough evidence for cases where it is most indicated. You can always justify its use in cases where it is most indicated. Most cases are against regional anesthesia, but still thoracic epidural is being performed day in and day out. If that can be justified, why not this one? Proper explanation and consent is must. Till the time it appears in the standard textbooks, we can keep our fingers crossed. Disability of segmental spinal, there are 4 aspects: technical, economic, legal, and operational. Technically, it's not very difficult and different from your routine lumbar spinal, especially at the low thoracic levels. Only at mid thoracic, it is slightly difficult. Economic, it's very, very economic as compared to other modes of anesthesia. Legal, still a question mark, but can be defended with strong indications. Operational, it can be operational at any setup with basic minimum facilities. Coming to indications, all intraabdominal surgeries, all open, lap, major, minor, upper, lower, they all can be done under segmental spinal. Even the breast and superficial thoracic surgeries, awake thoracoscopic surgeries, NEVAT surgeries, bulectomy, thymectomy, lung volume reductions, anterior mediastinal mass, wedge resection in non-small cell lung carcinoma, etc. Some prone lateral position spine, musculoskeletal, urological procedures, they all can be done. Only thing is indication of segmental spinal needs to match the surgical needs of the patient. Advantages of routine spinal or general anesthesia at times. The surgeries which were thought to be out of domain of spinal anesthesia, like upper abdominal, thoracic, and breast surgeries, are possible under segmental spinal. The higher levels of the block can be achieved with just half the dose that is required at the lumbar limits. There is minimal hemodynamic fluctuations, early recovery and voiding. Special advantages of general anesthesia in patients with respiratory comorbidities. Patient can be saved from going on to ventilator supports. There is lower incidence of post-op nausea, vomiting, and recurrent post-surgical pain. Cons and remarks. This applies to even your lumbar spinal anesthesia. Spinal cord damage is a potentially disastrous complication of dural puncture for any reason. Although rare but real than theoretical, fact that anesthetic technique is not usual does not mean that it's wrong. Concept has developed that regional anesthesia should need no supplements. If it does, it should be considered a failed block. This reasoning needs rethinking. Patient safety takes precedence for the necessary risks to be taken for success of procedure. There are 3 different modes of using segmental spinal. Either it can be single shot spinal for short to duration surgeries of 90 to 120 minutes, or it can be combined with epidurals. In epidural, in very morbid cases, it can not only act as a backup for segmental spinal, but by epidural volume extension technique, you can spread the low doses of intrathecal drug to wider segments. And epidural is also useful for your post-op analgesia. The third option is continuous segmental spinal anesthesia. It can be used as a primary technique, or it can be used when you get accidental dural puncture during thoracic epidurals. Drug options, either isobaric or hyperbaric drugs alone can be used. Either of the 2 from the 3 can be used. Isobaric, hyperbaric, or hypobaric. In general, isobaric drugs are usually preferred for laparoscopic, thoracoscopic, breast, and superficial surgeries, and also intraabdominal surgeries in morbidly frail patients where relaxation is not an issue. Hyperbaric drugs can be a choice for open surgeries in male muscular patients where you need good relaxation. There, hyperbaric drugs can be used. Hypobaric drugs are usually not used alone, but they can be used in combination with either isobaric or hyperbaric according to need. The advantages of isobaric drugs are they are less sensitive to position issues. They can be used in any position. Spinal can be given in any position. And in low doses, they have a propensity for a preferential sensory block, that is known as selective anesthesia. Onset is gradual, there is hemodynamic stability, early ambulation avoiding is possible. Spinal can be given directly in the operative position. For lateral position surgeries, you can give in lateral position. For prone position, you can give in prone position. Or the patient can turn on his own to the desired position. Suppose if you give spinal even in sitting position, patient can turn on his own without wasting much of time. Spinal can be given before epidural and at a space higher than epidural. Generally, using hyperbaric drugs, what you do is you need to give epidural first and then spinal to avoid unilateral or a saddle block. But here it can do reverse. You can use spinal before the epidural. Disadvantages of isobaric drugs. Levels of block cannot be modified by any change of positions. Like hyperbaric drugs, you can change the tilt of the table to increase the levels of the block. You need to decide beforehand the doses and the sites of injection for isobaric drugs. There can be sacral sparing when low doses at higher spaces are used. This can be an advantage for upper abdominal surgeries, but can be disadvantages in some pelvic manipulations. So you need to use the drugs accordingly. It has longer onset time at lumbar levels. It takes some time for onset because of the sacral roots are slightly thicker. There is less muscle relaxation as compared to your hyperbaric drugs, and they are also sensitive to temperature variations. It can become slightly hyperbaric when cooled at 24 and can become slightly hypobaric when warmed at 37 degrees centigrade. Amongst the available drug options, we have 4 ml ampoules of all the drugs now. Bupivacaine 0.5%, levobupivacaine 0.5%, ropivacaine 0.5 and 0.75%. Chlorprocaine was a very good drug, but recently they have withdrawn that, but it was very good for short duration surgeries. And amongst the hyperbaric drugs, till date we had only bupivacaine available, but now levobupivacaine and ropivacaine 0.75% is also available. Sorry. Additives, there are a number of additives, right from opioids to alpha-2 agonists, but additives which will not cause post-op respiratory depression and which will not lead to post-op nausea vomiting are generally preferred for short duration surgeries. Fentanyl is a very good additive, 20-25 micrograms. Dexmed is a very good additive to prolong the duration of the block in a dose-dependent manner. It has a propensity to prolong the duration in a dose-dependent manner, and also the side effects are dose-dependent. So you can choose your dose according to your requirements. Ketamine, though potentiating sensory block, is known to shorten the motor block time. If Dexmed is not available, then clonidine can be used in 15 to 30 micrograms. How to decide the dose and the site of injection? In general, 1 ml of the isobaric drug spreads 2 to 3 segments above and below the site of injection. What that means is 2 to 2.5 ml of drug can block segments from T2 to L5S1 when spinal is given at T10. 10 thoracic space lying in the center of the surgical field for upper abdominal surgeries. Dose of local anesthetic, additive, and site of injection can be varied according to need. For breast and superficial thoracic surgeries, it's preferably spinal needs to be given at mid-thoracic levels T4, 5, 6, but the dose you have to limit the dose of isobaric drugs, preferably isobaric drugs here, no hyperbaric drugs. Just 1.2 to 1.3 ml of the drug, maximum 1.5 ml including additive. Otherwise, you can have some respiratory or cardiac issues with such high levels of high doses of drugs at this level. Duration it can provide is 60 to 90 minutes or slightly more, even up to 2 hours if Dexmed is used as additive. Usually, you have to combine it with epidural or some blocks for longer duration surgeries. These are the different levels required for different types of breast surgeries and assessment for breast surgeries. For MRM, you need C5 T7. For mastectomy with transverse rectus abdominal flap, C5 to L1. For simple mastectomy, it is just T1 to T7. Epidural scoring scale for arm movements, which is used to assess the motor blockade during thoracic epidurals, can very well be used to assess the motor blockade during segmental spinal at this level. There are 4 grades, 0 to 3. Hand grip is C8 T1, wrist flexion C7 C8, and elbow flexion is C5 C6. This was a chart prepared by me and submitted to BJA for that article. You can have a screenshot of this. This is different surgical procedures, level of injection for those procedures, drug dose, volume, and concentration of the drugs, levels achieved, and what additional blocks can be added to this for post-op analgesia. For surgeries with unpredictable duration or longer duration, or in morbid patients where minimal drug is used in spinal, in those cases, it can be combined with epidural, or as I already said, it can you can go ahead with continuous segmental spinal anesthesia. I'll just briefly mention about pediatric segmental spinal anesthesia. We generally don't promote it because unless you are very efficient in doing a pediatric anesthesia, you should not go ahead with this. But I have one publication about pediatric segmental spinal also. Here, the neonatal CSF volume is around 4 ml per kg, is twice that of the adult. Infants lack thoracic hypothesis, can increase capillary spread, increase vascularity of the pyometer, greater cardiac output, myelin sheath not fully developed. All these lead to faster onset and offset. Dosing calculations need to consider child's weight, age, and developmental stage. Dose required in neonates is little higher in milligrams per kg. This is again a chart which was prepared by me. Doses of bupivacaine, levobupivacaine, ropivacaine for lumbar and segmental spinal in pediatric patients. And I just modified the scale, doses in milligrams per kg, ml per kg, and a fixed dose formulas. Now, the position of the patient for giving spinal. Using isobaric drugs, you can give any position, sitting or lateral. Plain bupivacaine, levobupivacaine, ropivacaine are slightly on a hypovaric side. Addition of fentanyl makes it slightly more hypovaric. So higher capillary spread may occur if the patient is kept seated for some time after giving spinal. Using two drug combinations, sitting position is mandatory for giving spinal. I will be coming to that later. Two drug technique. Type of spinal needle combined with epidural, CAC kit is the best and safest option. You can have a safeguard with CAC kit. There is a safety lock, and that can be the safest option when you are combining with epidurals. Either Quincke or pencil point needles can be used, but with Quincke needles, pencil point needles, you need to enter around 2 millimeters more inside the thecal space to get a free flow of CSF. And the incidence of paresthesia was quoted to be slightly more with pencil point needles because of this. Landmarks to identify intervertebral spaces, you can from surface markings. C7 is vertebral prominence. From here, you can count your space required. Then root of the spinal scapula is T3, inferior angle of the scapula is T7. Lower rib margin is around 10 centimeters from the midline. Then your intercostal line, that is a landmark we always use. Then if you have ultrasound, you can use the ultrasound, count upwards from FIS1 in parasagittal oblique view to locate the required interspace, identify the 12th rib and count upwards, or identify the first rib and count downwards. You can locate the interspace according to this. There are some anatomical hurdles for thoracic spinal. Spinous process T4 to T9 are sharply angled. Spinal processes are not always in a straight line. They are undulating and there can be lateral angulations. There is one lateral curvature in the thoracic spine also. Apart from the thoracic kyphosis, there is one lateral curvature, and because of that, there are some lateral angulations in the spinous processes. They are not always in the straight line in a perfectly normal patient also. And the interspaces are very narrow at this level, difficult with the midline approach at mid-thoracic level. So paramedian or paraspinous approach can be used. This is just to show the anatomy at the mid-thoracic levels. You can see very narrow interlaminar spaces. They are not visible at T7, 8, 9 levels. There are some landmarks which are important to note at this level. The upper margin of the transverse process usually corresponds with the interlaminar space at these levels, and the lower margin usually corresponds with the safe landing spot, what we use in a paramedian approach. I'll be coming to that later. And this you can identify with your ultrasound if that is available. This is just an imaginary process, illustration of how lateral to midline entry with some upward inward angulation can open up the interlaminar space at these levels. Just imagine that your needle tip has an eye or camera on it. And everything from skin to the interspace is transparent. In the first image, you can't see any open interlaminar space. When you go perpendicular, just 1 centimeter lateral to the most prominent part of the spinous process and hit the safe landing spot, in the first image, you cannot see anything. But when you turn the hub of the needle a centimeter down to create a 60-degree angle in the second image, you can see slightly opening up of the interlaminar space. And then when you turn the hub of the needle around 5 millimeters laterally in the third image, you can see the interlaminar space has opened up quite nicely. This is how it can open up during your paramedian approach. This is just an illustration. The same thing, paramedian approach for thoracic spine. Go perpendicular to the most prominent part of the spinous process, hit the mid-laminae, and then upward and inward angulation. Step by step, you can reach to the interlaminar space with this approach. The needle approach in scoliotic spine. This is important because spinous processes are not always in the straight line, and there is some undulation, just like your scoliotic patients. So the approach here, the vertebral body usually rotates towards the convex side, and the spinous process rotates towards the concave side. If you want to go through the midline, you need to go towards the convexity, as shown in the image. And if you want to go a paramedian approach, then you need to go from the convex side. From concave side, you will not be approaching the interlaminar space. This is just the illustration of the same. For midline approach, go towards the convexity. For paramedian approach, go from the convex side. Convex side is opposite to where the spinous process has rotated. This is another approach, paraspinous approach, just 0.5 centimeters laterals to your spinous process. It can be done ultrasound guided, or it is also useful. It can avoid your upward inward angulations in just 0.5 centimeter lateral, keeping an angular just 5 to 10 degrees, just one angle. I'll have some video about this. You can see this video. Keeping the angle just 5 to 10 degrees. You need to go just half a centimeter lateral to the spinous process. Giving too much of an inward angulation can make you go to the opposite side paravertebral space or even the intrapleural space. The same thing can happen when you think you are in the midline, but you come out of the interspinous ligament and finally end up in a paraspinous approach. This is how paraspinous approach can be done in patients with in a lateral position. Just keep your two fingers at the upper margin of the lower spinous process, and the tip of your finger, middle part of tip of your finger can be a guide to your needle insertion. These technical aspects of spinal anesthesia, I have a separate presentation in detail actually. Can't go in very much detail at this moment. Then ultrasound imaging of the thoracic spine, T10 to T12 are similar to lumbar vertebrae. T4 to T9 are steeply angled spinous processes, and there are overlapping laminae. Very small window in the parasagittal oblique view and no window in the transverse view. Transverse view is hardly of any use apart from locating whether it is scoliotic or the spinous process on the midline. The transverse view is hardly of any use. You can see the transverse view, the parasagittal, then parasagittal oblique view to locate the interlaminar spaces. You can do ultrasound guided, mark the space, or you can do ultrasound guided also. This is how it looks in the parasagittal interlaminar view at the thoracic spine. You can see the narrow interlaminar spaces. The laminae are flat leaf-like as compared to the sawtooth or horse-head appearance at the lumbar levels. These are flat laminae. You can see the posterior complex and anterior complex. If you are able to see the anterior complex through this view, that means that space is open for giving you spinal. If you are not able to see the anterior complex, look out for another space. This is transverse view, just to see whether this is in the midline. You can see the laminae, and laterally you can see the ribs and pleura. This is USG guided paramedian X view. This is just another modification of the view where the probe is turned medially to the spinous process of the vertebrae above and transverse process of the vertebrae below. This is the X view for ultrasound guided spinal at thoracic levels. There are some safety measures for successful use of segmental spinal. You need to do a thorough pre-operative assessment of the patient as to the comorbidities of the patient, the drugs the patient having, and all neurological, if there are any neurological issues or all. What are the dermatomes that will be involved in that particular surgery? You need to talk to your surgeon about the extent of your surgery, the duration or likely duration of your surgery. So according to that, you can choose your mode of segmental spinal, drug doses, etc. If ultrasound is available, you can do a pre-procedure scanning, identify the landmarks properly, selection of the proper drug dose site and mode of segmental spinal according to need of the surgery and surgeon, because many surgeons are slow and some are very fast. So according to your surgeon also, you can choose your everything. Assessment of the levels, monitoring and proper sedation after giving segmental spinal. I'll just skip this. I don't know how many of I have done. Initially used for only high-risk cases, now occupies nearly 50% of my CB profile. Till date, very few partial failures, but fortunately no mishaps. There are many presentations and all. I usually do a complete pre-anesthetic evaluation of the patient, emergency airway card drugs ready, venous access, minimum entry monitoring is applied. No sedative pre-medications are used. I usually prefer lateral position for giving spinal. Spinal is given lateral position with 27 gauge needle. Speed around 1 ml per 15 seconds. Drug dose, site, mode according to patient and surgery. For intra-abdominal surgeries, I used to use chlorprocaine for short duration surgeries, but nowadays it's not available. So I use just isobaric drugs for short duration surgeries without additives. For mid duration surgeries, around 60 to 120 minutes, either isobaric or hyperbaric according to need with some additive. Average female patient 2 ml plus additive, average male patient 2.5 ml plus additive. This is for ASA12. And for patients with morbid illness, I usually combine them with epidural, giving a low doses intrathecally. And with this, I usually combine them with some interfacial plane blocks, tab block, rectus sheath block, erectospinal plane block for open surgeries, or local anesthesia at the port site for laparoscopic surgeries. Breast surgeries, I have already told you. Recently, I started combining erectospinal plane block with segmental spinal for breast surgeries. 2 days before, I did one MRM with level 3 dissection. So the patient was mobile within 3-4 hours. She took oral within half an hour, and she shifted herself from table to stretcher also. Coming to 2-drug technique, combination of any two, either iso, hyper, or hypobaric. What happens when you use only isobaric drugs at mid to lower thoracic levels? There can be some sacral sparing. And for some abdominal pelvic surgeries, if you have used adequate dose of isobaric drugs, the sacral roots do get involved after some time, but they take some time for onset. In those cases, what you can do is you can take just 0.3 to 0.5 ml of hyperbaric drug initially, and then 1.5 to 2 ml of isobaric in different syringes, spinal in sitting positions, like for TLH, for your PCNL surgeries where some pelvic manipulation is needed. In those cases, you can use a combination of hyperbaric and isobaric. And for lap choles, when you need to have some adequate levels to avoid the shoulder hip pain, and the patient is kept in a head-up position, so you can take the advantage of that position by using hypobaric and isobaric drugs. Hypobaric drug will take care of the cervical roots because the patient is kept in a head-up position. You just take a 2 ml of 0.1% hypobaric and around 1.5 to 1.8 ml of isobaric at around T10 levels. After giving segmental spinal, the patient turned to desired operative position. Sensory block tested by pinprick, sets in 3 to 4 minutes. There is minimal hemodynamic fluctuations. Usually In the first 10 minutes, no respiratory issues, even with high levels of block. Initial partial involvement of thermosacral roots can be seen, depending on the dose you have used. Usually, no additional supplements are required. Patient can be completely mobilized in 4 to 6 hours. To sum up, it's a very useful technique with many advantages, minimal risk with due precautions, no need to panic, even if block level is found to be higher than desired. Lab surgeries may need little sedation. If available, ultrasound can be helpful for more safety. Technique is reserved for experienced clinicians, good learning curve. Now, some comparison between the segmental epidural and segmental spinal. These both things are quite similar in their behavior, but there are some differences between them. Similarities are both produce segmental block with minimal exchanges. Injection site is most importantly both should be in the middle of the dermatomes. Concentration of the drug affects the density of block in both. Lower the concentration, more selective the block is. But there are some positives about segmental spinal. It's economic, quick, with definitive endpoint. There is early onset, uniform dense block with minimal drug. Then failure rate is low, even in cases of previous spine surgeries and deformities. With epidural, you can have some patchy effects. Chances of last are negligible as the dose used is just 1/10 of what is used in the epidural. There is good relaxation, requirement of sedation is very less. The only thing drawback of segmental spinal or epidural is there is no versatility to extend the level or duration of block and are also not useful for post-op analgesia. This is just a repetition. I'll skip this. These were the 20 points made for in 2023. This is just repetition of the same thing. The other important part is do's and don'ts in segmental spinal that I'll cover in briefly. So before proceeding in the do's, you should know in detail about the technique, what are the various drugs that can be used, what are the drugs that are available with us, what are the different doses required for that particular surgery, additives and the sites of injection for that surgery. Then you should know about your surgeon also, how adaptable your surgeon is to the changed conditions provided by your regional anesthesia, how flexible and efficient your surgeon is. Accordingly, you can choose your mode of segmental spinal. Then you should know about the surgery also, whether it's open, lap, what will be the duration, likely duration, and the extent of surgery, what the dermatomes that will be involved. About the patient, how cooperative your patient is, willing for sole regional or not, what are the comorbidities, risk-benefit ratio of general anesthesia versus segmental spinal. Then always use the position you are accustomed to, no matter whether it's sitting or lateral, unless you are using two-drug technique. Do a pre-procedural ultrasound in difficult spine. Use a CSC kit if you are combining with epidural for more safety. Do always use multimodal analgesia with segmental spinal to avoid post-op nausea, vomiting, and respiratory depression. Always do prepare and keep ready your backup plan. In the don'ts, don't force your surgeon to do it under segmental unless there is strong indication in favor of segmental spinal. If the surgeon says he is not comfortable, don't go ahead. Don't be rough and rusty, advance gently, millimeter by millimeter. Don't proceed if there is slightest paresthesia, withdraw the needle and change the direction. Don't use higher doses of local anesthesia at mid or high thoracic levels. The dictum is higher the space, lower the dose. Lower the space, you can use slightly higher doses. Don't unnecessarily add too many additives together. Just because someone is adding 2 additives, don't add it unless you are well versed with their behavior. Don't use excessive sedation with high levels of blocks. Don't panic with early hemodynamic and respiratory issues. They are usually minimal, gradual, and easily manageable. Though it's possible to do even thyroid and for extremity surgeries under segmental spinal, it's not recommended to use this technique for such type of procedures as there are more safe and less invasive blocks available for these surgeries. Don't use it in pediatric patient unless you are well versed with other aspects of pediatric anesthesia. Don't hesitate to call for help or communicate in case of doubts. Future prospects, AR, VR can help. AI can come into picture in future. They can aid in this thing. AI guided segmental spinal can be there. I will just go through quickly my videos, some of my videos. This is just to show how straightforward it is at the low thoracic level. This was a patient for umbilical hernia. I'm using a 27 gauge needle. It is around T11-12 level, I think. not much of angulation. This was our second-year resident who was giving spinal. We did a pre-procedure scan. Patient was 130 kg in sitting position. Just to show how gently you have to go step by step, removing the stellate at every loss of resistance. He is going via paramedian approach. Go gently. This was probably also some epigastric hernia. These videos I am showing in detail just to have a look at how gently you have to proceed step by step, removing the stellate. No harm in taking some time. This was done under supervision by us. Our second-year resident was giving spinal. I think she has done. So it was just to show how gently you have to proceed. This is a lap chole in a very morbid old patient, IHD, with hypertension, diabetes. This was done under segmental spinal. This was with single drug with ETCO2 monitoring. This was did a long back. Initially, I used to do it with combined with epidural breast surgeries. And this case, the epidural was put at T45, spinal was given at T56. The levels being tested, you can see how comfortable the patient is, even with such high levels of block. This is some 8-10 years back when I used to do it with epidural. There was no sensation at C8, but the grip strength was good, indicating only a sensory block. This is MRM being done. This is again around 2017 or 18. This was the first time traumatic diaphragmatic hernia was done under combined segmental spinal and epidural. You can see the whole of the hemithorax was filled with the intestines. In this case, the spinal was given first at T78 and epidural was put at T89 level. The diaphragmatic mesh repair is being done in the same patient. The same patient at the end of surgery is completely moving his limbs. And the next day X-ray of the same patient. This was done some 6-7 months back. 6 days old jejunal perforation. Patient was in sepsis. 55 years old male. Segmental spinal rate 2.5 ml. Hyperbaric BP again. Because it was a male muscular patient with tight abdomen, it was done with a hyperbaric drug. You can see the blood pressure chart there. This was a obstructed umbilical hernia. Again, a very old case. It was done under combined segmental spinal and epidural. You can see his respiration. This was a huge ovarian cyst. Again, a old case, 2-drug technique, 0.5 ml of the hyperbaric and 2 ml of isobaric at T12 L1 levels in sitting position. First, the hyperbaric was injected, 0.5 ml, then isobaric was given. It was thought to be a malignant cyst. In spite of the whole length incision, the cyst had to be ruptured. Cystectomy, omentectomy, hysterectomy, and lymph node dissection was done. This is lap chole with 2-drug technique, what I was talking about. In this case, the 0.15% of hypobaric was used, but just 0.1% of hypobaric is sufficient. 0.1% means 1 ml diluted with 4 ml of distilled water, so that it makes around 0.1%. Or out of that, only 2 ml is given, and 1.5 ml of isobaric bupivacaine. The levels were quite high up to the cervical roots, C7, C5. She had no shoulder tip pain. This is NEVAT, segmental spinal for non-intubated video assisted thoracoscopic surgeries, massive pleural effusion for thoracoscopic pleurodesis. Just 1.2 ml of segmental spinal in lateral position and continue in the same position. This is again MRM, epidural and spinal. This is again an old case. The same patient shifting at the end of surgery. TLH with two-drug technique, total laparoscopic hysterectomy. This is CA vocal cord with posterior occlusion for feeding gastrostomy, because it could not be done with gastroscopy. So it was done open. Spinal was given a T89 with just 1.5 ml levobupivacaine, and bilateral rectus sheath block was given. I have done more than 40-50 ruptured ectopic intersegmental spinal with for short surgeries. I used to use chlorprocaine, otherwise isobaric drugs. You can see the whole abdomen filled with blood. This was a patient with atlantovesical dislocation with vacillary invagination, and she had diffuse disc bulges with at C5-6, and her C1 C2 fixation was done with limited mouth opening. She was a relative of a doctor, and she was very much worried about her neck movement. She said that she will not allow to touch her neck because she gets giddiness while touching her neck. So gave her the option of segmental spinal to the doctor with her, and they accepted it. And I just touched her neck just to put a nasal prong. Otherwise, it was done under two-drug technique only. This is ruptured liver abscess in a 21-year female. Hemoglobin was 4.9, CRP 43.9. She was in sepsis. You can see the whole abdomen is filled with pus, thick pus. This is how we usually monitor ATCO2 when special probes are not available. I cut a 12 gauge nail cap tip and attach it to ATCO2 probe. This is probably simple appendicectomy, a patient shifting at the end of surgery. This is the mother of a doctor for hysteroscopic removal of a polyp, spinal in sitting position. This is after 1.5 hours of the surgery. She is the bed. After 3.5 hours, she was ready to go home. This is a patient of difficult intubation for laparoscopic cholecystectomy. Somehow we intubated the patient, but the resident there thought that it's not there, and she removed the tube. But then it could not be put again. So that patient was postponed by the surgeon. Next time he came, and I convinced him for segmental spinal, and now he's watching his own surgery. This is male MRM with erector spiny plane block first. This is erector spiny plane block, taking the transverse process. The patient shifting at the end of surgery. This is again MRM, degenerative heart disease, again erector spiny plane block. The same patient going to bathroom after around 4 hours. These are some pediatric cases, 12 years old, twisted ovarian cyst. According to formula, 12/8, 1.5 ml. I usually use Dexcat as a sedation for pediatric patients. This is again a pediatric patient, probably perforated appendix. This is again 8 years old, perforated appendix. These are my various publications. There are a few more yet to be added to this list. This was my book published in 2023, handbook. And thank you very much for patient listening.
Thank you, sir. Thank you for that wonderful talk on segmental spinal anesthesia.
I hope it was loud and clear.
Yes, sir. It was absolutely a pleasure hearing to the master himself. And I think we are really happy to have witnessed this presentation. It was excellent with all those
It
videos.
was slightly longer presentation, almost.
Sir, actually, you have shared your experience. No, that is what counts. And we are really happy to have you here with us. And I think there will be some questions, definitely. There will be some
yes, would like to have.
queries. So,
Sir,
sir, I would like to ask you, sir, how do you decide whether a patient is a good candidate? Or rather, are there any red flags or specific contraindications?
Contraindications which apply to your lumbar spinal, they apply to here also. And other applications are usually, I just interrogate the patient about his anxiety part and all, and try to convince him for segmental spinal, giving all the advantages. And if the patient is not willing, then usually go ahead with the other modes also. But if the patient is very high risk, then I try to convince him for the advantages of your segmental spinal.
Thank you, sir.
Sir, am I audible?
Yeah.
Sir, I have a question. Rather, actually, you have already cleared it. I was thinking about the concern was the post-operative analgesia, sir. But then you have already told like you can add additional blocks and so.
Yes, depending on the surgery, you can use those blocks, and I generally use dexamethasone, diclofenac, and paracetamol as a multimodal analgesia. I generally avoid the drugs which will cause post-op nausea, vomiting, and respiratory depression. The narcotics and all, I usually avoid those because early ambulation, early voiding, and early intake is the motto. Most of the patients for short duration surgeries are discharged within 6 to 8 hours.
And the next concern is like actually in PG institutes where your postgraduates are going to operate, what we think would be a short procedure would actually extend.
Yes. There we nowadays, depending on the surgeon, not only surgery, we choose the additive.
Yes.
If you choose additive like Dexmet, it provides quite a long duration with a similar dose, just 2 to 2.5 ml. It can provide duration around 3, even 3.5 hours if you use more than 5 mcg of Dexmet. I have seen the Dexmet acting even for 6 to 8 hours if you use around 10 mcg of Dexmet with the same dose. So depending on the surgeon also, we choose our mode of anesthesia, either combined with epidural or single shot. Now, this is routine in PG, I mean, medical colleges where the residents are doing the surgery. If the patient is very high risk, then we ask the senior surgeons to go ahead with the surgery to avoid any complications.
Sir, and just want to know how much, how were you able to convince the surgeons, sir? I think it's really a
still
task.
still difficult to convince. But when the patient comes, we had so many cases in last month. The surgeon himself, they brought the patients from outside for segmental spinal to our institute. So in those cases, you don't need to convince them. They themselves happily agree for that. Still there is some reluctance, but I'll tell you, there was one surgeon at my place who came here just 4-5 years back. He came from Tata. He was very reluctant about breast surgeries in spinal. But initially 2-3 patients with very high risk, and he did with me. And now his anesthetist is doing with him, not even me.
And,
all cases under segmental spinal. So once they see the benefits, they get convinced.
Sir, had you were you supposed to go through the ethics institute ethics committee when you just started, because it is supposed
There
to
are
be
many
considered as a
PGs
new
who have
technique.
taken this as a thesis topic. I know at least 10-15 PGs all around India who ask me what to take. Even in my institute, there are 3-4 PGs who have taken this as thesis topic. And now there are enough publications on this.
Yes,
so I don't think it is a hindrance to
Thank you, sir. Thank you for the explanation, sir.
Thank
It was
you.
indeed great listening to you talk about this, sir.
Thank you.
Thank you, sir. Sir, is there any relaxation issues?
You need to choose the drug according to your patient, actually. Now, they have come up with isobaric bupivacaine. The isobaric bupivacaine is very potent drug. When you want to use isobaric drugs, you can choose bupivacaine, which has a very good relaxation. And if you think that the patient is very male, muscular, and you need a good relaxation for intra-abdominal surgeries, then you can use hyperbaric drugs. The only thing is you need to keep the gravity-dependent spread in mind. Once the adequate levels are achieved, you can change the tilt of the table and keep the levels to what you want to. So you can choose the drug, your additive, according to your choice. For females, multiparas patients, usually there is no issue, even with isobaric levobupivacaine or even ropivacaine.
Yes, sir. Thank you, sir.
Excellent presentation, sir.
Thank you.
We did few cases with thoracic spinal anesthesia, sir, but we used little lesser volumes, maximum 2 ml. That's why our
2 ml is enough for which
yes,
surgeries?
lap cholecystectomy, sir. Our
At what
success
level?
rate is decided by surgeon's
Surgeons.
tissue handling and the duration of surgeries.
No.
If the surgeon is good, the
Yes,
patient used to be very much comfortable.
many surgeons can do lap chole in 15 minutes. There are few surgeons who can take around 2 hours.
Yes, sir. Yes,
So
sir.
what I
That's
said
right.
is you can use 2-drug technique also for lap
Yes,
chole
sir.
to have better results, so that there is no shoulder tip pain.
Yes, sir.
You can choose the drug and mode of segmental spine according to your surgery, patient, surgeon,
We
everything.
missed a hypobaric combination, sir. We used to mix
You can
isobaric
next
and
time you can try
hyperbaric for
just
relaxation.
no, hypobaric will not give relaxation. Hypobaric will provide
Yes, sir.
adequate higher levels,
Yes, sir.
and your isobaric will
The
provide.
patient used to complain shoulder tip pain.
Yeah,
Sir,
that's
why.
because of inadequate levels achieved.
Yes, sir.
There are many other things we can do for shoulder tip pain. Some people, they instill local at diaphragmatic site.
Yes,
Some
sir.
people can give the superficial cervical plexus block, just the lower supraclavicular root and transverse cervical. So there are few things you can do. Or what I do is I use Dexcat. Dexcat is the best sedation. Dexmedetomidine and ketamine combination. That is the best combination, which does not hamper your airway tone and reflexes and keeps the reflexes intact, and also does not change the respiratory pattern. Because if you use higher sedation, then the respiratory pattern may change and may disturb the surgeon. So unless you are thinking of securing your airway with some supraglottic devices, don't use heavy sedation.
What are the incidents of bradycardia and hypotension, sir?
Usually with the doses I suggested, it's not there, but you need to monitor the patient intensively, vigilantly during the first 5 to 10 minutes. Whatever happens is within 5 to 7 or 10 minutes. But it's not very much if you restrict to the dose guidelines and all. And also depends on the patient's previous comorbidities and all, patients, the drugs he is taking. But usually it's not an issue.
What is the most learning curve for the any postgraduates or any new learning curve? How many thoracic spinal should be done? They become an expert.
See, if they are doing thoracic epidurals right from the first year of their postgraduate level, they can very well go with thoracic spinal. At low thoracic levels, it's not very difficult. They can start doing it for simple cases like umbilical hernia, epigastric hernia. What you need to do is just around T10, 11, 12, just around 2 ml of the drug with some additive, and along with that rectal sheath block. That's all what is required. And patient don't need catheterization. Patient can be early mobilized, early intake. with this much. Day before yesterday, I did a very high-risk patient of umbilical hernia. He took oral within 1 hour. He was not catheterized. He was shifting himself from the table to stretcher. He was very high risk. I mean, a lot of respiratory issues and all. These are the advantages in specific patients. So start doing it in cases where it is most indicated, so that the thing is you can justify your segmental spinal, and if you get success with these high-risk patients, you get confidence to do it in your other cases. So it's reverse. We generally ask the people to start doing it in cases where it is most indicated, so that you can always justify your doing this.
What we advise for the additive drug should be added to the original drug, or you can separately should give it.
No, we generally
additive
add
drug.
it to the additive, drug only. Or this
No,
fentanyl.
it would varicity will change, sir. When you
Yeah,
add
yeah.
the
Yes.
that's why you separately should give it. If you give add fentanyl or something
Even
like
if
that.
you give separately, the thing is isobaric drugs are slightly on the verge of being hypobaric. And if you add fentanyl to it, the fentanyl has a density of 0.99360. It is quite hypobaric. If you add fentanyl to an isobaric drug, it becomes slightly hypobaric.
Okay.
And that is advantageous for some cases. I mean, it can spread higher up. If you give in sitting position, adequate levels are achieved for laparoscopic surgeries. And you can combine with hyperbaric for your pelvic involvement. And Dexmed is used in a very low dose, just flush of the syringe, so it does not change the baricity of the drug. Dexmed, we just rinse the syringe. Depending on the syringe you use, it can be either 2 microgram, 3 microgram, 5 micrograms. So just flushing of the syringe, or if you have that BCG or insulin syringe, you can take the accurate dose. You can add to the local anesthetic and give it. No need to give it separately. With Dexmed, it does not change the baricity. Only with fentanyl to isobaric, it can change. With hyperbaric, if you add fentanyl, it will not change the baricity of hyperbaric drug. It will remain hyperbaric only.
Do you have in India, we have hyperbaric local anesthetic like bupivacaine or ropivacaine?
No, hypobaric is not available. You need to prepare hypobaric.
One.
Isobaric, we have available 4 ml ampoules of every drug now. We have isobaric bupivacaine available from Flagship Biotech.
Even that is also sterile is not available.
Yeah,
sir.
sterile,
ETO sterile and also not sterile, preservative free.
Yeah, preservative free, sterile, ETO sterile ampoules are available of bupivacaine, bupivacaine, and ropivacaine.
Now it is okay.
Previously, we used to use it from vials also. They are also preservative free. Bupivacaine and ropivacaine. Bupivacaine was not it was with preservative. But now 4 ml ampoules are available.
Which company, sir? Do you have what company? Now,
Flagship Biotech
Neon is available. Now,
Neon, with Neon, bupivacaine 4 ml ampoules are available. And Flagship Biotech is providing bupivacaine and ropivacaine 4 ml ampoules, ETO sterile and preservative free.
Okay, thank you. Thank you, sir. It's a wonderful lecture, and especially with a lot of experience. The people are benefited with your knowledge and what you have delivered a good with example and a very lot of case discussions. Thank you.
Actually, we have more presentations on hypobaric, continuous spinal and everything, but it takes a very long time. It goes on for a long time. So
basic now
I
the people are
myself to segmental spinal.
That is most important. The people should aware what is the basic now. Then they can practicing.
Yes.
Then they can listen from you advanced. without practicing, going on and listening the advanced is not at all useful.
And we have recently formed a society actually, Neuraxial Anesthesia Development Society, and there are many members who have joined this. So we are all doing different types of different modes of segmental, not only segmental, but
You're
isobaric,
doing any
hypobaric.
workshops, sir? If any, the people are workshops are there,
Yeah,
we can.
recently we had one in Jaipur last 15 days back only, and we
Okay,
have
okay. We'll plan
interactive
a
of-
workshop, sir, here, Visakhapatnam. I'm Dr. Kuchel Babu. I think you know.
we
right?
had
We'll try
a
to.
few in South also. I was there in Kanyakumari. I was there in Madurai also. I was,
We have
recent-
a simulator mannequins you have available for the for this.
mannequins we are just trying to procure because the
Okay,
mannequins
good.
available are not very good. They just
Okay.
are not
Okay.
properly made.
Okay.
It was available in USA, but I could not bring it here because it was not allowed. So we are trying to bring the mannequins.
Yeah, previously I know there's some glass models are available. I don't know now it is available or not.
Glass
Previously
models
fine.
only just
Yeah.
depict the isobaric,
The
hypobaric,
drug,
and
the colored the drug will be shown.
yeah, there are some videos also available on
videos
YouTube.
and actual also models are previously available. I think now it is available. I don't know.
They are the videos are available on YouTube also.
Yeah.
Tarun has made one video also
Yeah.
about the spread of different drugs, different varicity drugs. But they usually don't take into account the baffles created by the spinal cord and cordine vena. It is just to show what hypobaric is, what isobaric is, and what hyperbaric is. Gravity dependent spread.
Thank you very much.
Thank you.
One question in the chat box, failure rate for a beginner.
As I already said, is you need to have a backup plan always. If you go according to the everything, I mean, you do a proper evaluation of the patient, proper evaluation about the type of surgery, the extent of surgery, and use a proper drug, the failure rate is very low. The failure rate in the sense you may not achieve proper levels if you are not used to proper space for giving spinal. Usually the failures are more about the proper levels not achieved, proper duration not achieved. So by doing the cases, you yourself can know what to do in the next patient.
Thank you, sir. Any more questions?
No, sir. As I've just checked, there are no further questions.
With the permission of the moderator, shall we wind up the session, sir? Vote of thanks.
Sure, sir. I think we should.
Sir, on behalf of ISA Visakhapatnam City Branch, I extend my heartfelt thanks and gratitude to Dr. Naresh Paliwal, sir, for an outstanding session. Sir, your deep insights and the clarity and depth of knowledge have truly enriched us. A warm thank you to our respected moderators, Dr. Vijesh Venugopal, sir, Dr. Pratibha ma'am, and Govardhani ma'am, for your valuable perspectives and smooth coordination throughout the session. So we're deeply grateful to the senior leaders like Kuchela Babu sir, who interacted very well, and other revered faculty from across the state. Your presence and meaningful interaction added great strength and spirit to today's session. We also thank ClearNet for their excellent digital partnership for ISA Visakhapatnam and continued support in delivering seamless academic events. And finally, to all our attendees, thank you for joining us and being a part of this wonderful evening of learning. Let's keep the momentum live because every session shared is a step towards a safer and smarter anesthesia care. Jai Hind, long live ISA. Thank you and good night.
Thank you so much, everyone, for joining this session. ClearNet is really glad to have all these brilliant people together. So with all your permission, I'm closing the session for today. Thank you so much,
Thank
everyone.
you very much for giving me this opportunity. And thank you all the moderators and Praveen. Thank you.
Thank you, sir. Thank you. Thank you.
Good night.
Good night.